Welcome everyone to today's Insight and ABSAT webinar. My name is Irene Francisco and I'll be hosting today's session. Before we get into introducing our presenter today, I would like to begin by acknowledging the traditional owners of the land on which we are meeting today. So I'm here in Brisbane, Meanjin on Turrbal and Yagara land, and I'd like to pay my respect to elders past, present, emerging, and welcome any First Nations people who are joining us today. And today is actually, it's National Sorry Day. So it's really important for us to acknowledge the impact of colonisation on our First Nations people. And I guess today's topic is also a useful little segue for that as well, recognising that the introduction of tobacco and use of tobacco with our First Nations people as payment has led to some of the increase in gap of, in terms of health outcomes for our First Nations people. So I would like to introduce our speaker today, Associate Professor Coral Gartner, whose main research interest is in evaluating strategies to reduce the harm from tobacco use. Carol is the director of the new Centre of Research Excellence on Achieving the Tobacco Endgame. Her research spans epidemiology, modelling, qualitative research and policy analysis. And I'm really pleased and really interested to hear from Carol about her topic today. Can we achieve, oh sorry, Coral. I've been saying Carol, Coral. And here's my dyslexia. So Coral's presentation on can we achieve a tobacco endgame, or is it a pipe dream?
Okay, so I'd just like to thank you for the opportunity today to present on the topic of the tobacco endgame and to give you an overview of some of the research that we have underway at the Centre of Research Excellence on Achieving the Tobacco Endgame. So before we get started on discussing the end of the cigarette epidemic, it's worthwhile revisiting how the epidemic started and then how it's developed, so we can understand, the origins of this major health problem that affects so many people. So what you see on the screen here is a graph that shows the rise in smoking among men and women that occurred in most of the high-income countries, so Australia, UK, USA. And so you can see here that it started with men taking up smoking after 1900 and followed by about a 20-year lag before the rise in male deaths from smoking-related diseases started to peak. So you can see that smoking really only became a widespread activity after 1900, rapidly increasing among men following the First World War and peaking in the 1950s, with more than half of all men smoking cigarettes. Smoking among women also increased over the same time period and peaked in the 1970s at a lower peak than amongst men, but still, substantial numbers of women taking up smoking as well. So, what explains this uptake in cigarette smoking that occurred in the first half of the 20th century? So, firstly, it's mass marketing. The invention of the cigarette rolling machine in around 1880 greatly increased the production of commercially produced cigarettes, and this led to, a drop in prices and just more of the product available. So there was also aggressive marketing and advertising, which increased the consumer demand for cigarettes, and other advances in manufacturing, such as using flue-cured tobacco and addition of ammonia, enhanced the uptake of nicotine from cigarettes via the lung. So these sort of innovations in cigarette manufacture made the cigarette smoke easier to inhale deep into your lung, and it increased the addictiveness of cigarettes. So the epidemic of tobacco-related disease that we've seen in the last century really was an entirely commercially driven and avoidable epidemic of like lung disease, cardiovascular disease, and so on. So the evidence of the health effects of cigarette smoking started to become more widely known as some major studies were completed in the 1950s. So there were landmark epidemiological studies by Winder and Graham in the United States and also by Dolan Hill in the United Kingdom. And these studies started to outline that people who smoked were far more likely to die early and die many years earlier than people who didn't smoke, and that they were dying from causes such as lung cancer was a major relationship there. So they had noticed that there was this increasing number of lung cancer cases, and there was a bit of uncertainty about what was causing that, and these studies showed definitively that it was the rise in smoking that was leading to this epidemic of lung cancer. So following these studies, there were also two major reports that summarised this growing evidence base, and they were published in 1962 by the Royal College of Physicians in London and in 1964 by the United States Surgeon General. And both of these concluded that cigarette smoking caused lung cancer, other respiratory diseases, a number of other cancers, cardiovascular disease, and gastrointestinal disorders. So these reports really heralded the peak in smoking prevalence and the start of the decline in smoking. But smoking did not rapidly disappear, and indeed smoking prevalence continued to increase among women after this time. So in hindsight, it's reasonable to wonder why health authorities didn't take a more definitive action on cigarettes, given the mounting evidence of the risk of serious illness and premature mortality from smoking. A number of factors probably contributed to a preference for approaches such as public education rather than removing the product from the market. Firstly, there were concerns about the public acceptability of banning cigarettes when a majority of men and a substantial minority of women smoked. Legislators may also have been a bit nervous about taking action that would affect so many voters, and they likely wanted to avoid being accused of being prohibitionists. There was also likely an assumption that people would just naturally stop smoking once they were informed of the harms, and this did certainly occur to an extent. However, the fall in smoking has not been as rapid as the rise. So also health authorities probably did not appreciate just how addictive cigarette smoking can be, and they may have also underestimated the activities of the cigarette companies who engaged in a campaign to create doubt about the health risks of smoking in order to maintain their substantial profits. So this all delayed people's quitting activities and caused a bit of confusion amongst the public about just how harmful smoking was. So this incremental approach was taken, and it's over the last 60 years, following the first Royal College of Physicians of Smoking, that a range of public health measures have been enacted, including mass media campaigns to discourage people from taking up smoking and also to encourage them to quit, banning cigarette advertising, so stopping all promotions of cigarette products, banning smoking in public places, and this is primarily to protect non-smokers from being exposed, but it also does encourage people to quit smoking, adding health warnings to cigarette packs, tobacco taxation, and we've seen some major increases in tobacco taxation over the last few years, provision of smoking cessation assistance in the form of behavioural support, and also smoking cessation medicines, and a number of those have been developed over the years. These have largely focused on reducing the demand for cigarettes rather than reducing the supply. And they've often started with basic versions of the policies, and then they've gradually been ratcheted up in intensity. So we've seen that, like a great example is the tobacco taxation. So over the last number of years, the Australian government's, increased the rate of taxation every year. So that, ratcheting up with that approach. So these tobacco control policies have actually been quite successful in reducing smoking. So for example, around 43% of adults regularly smoked in Australia in 1964, compared with 13% in 2019. So that's a major reduction in smoking. But if we also consider the time frame there, that's taken a long time to reduce smoking, and the number of people who have died during that time from smoking related diseases has been quite substantial. Also, it's worth noting that these overall percentages hide the much higher prevalence of smoking among different population groups. So, you know, people with mental health disorders or alcohol and other drug use have very high smoking prevalence, and that level of smoking can be hidden when we're just looking at, you know, the whole population. So now I'd like to move on to talking about what is the endgame. So that's the past, that's the history of where we got to with this. Now, as we've seen smoking prevalence decline down to around 15% and less, there has been a growing discussion. So over the past 20 years, a number of public health researchers have started considering what it might take to permanently end the cigarette epidemic. Plans for how to achieve this have often been described as the tobacco endgame. So the following are some suggested elements of a tobacco endgame goal and what conditions might be needed to achieve it. These were proposed by a group of New Zealand researchers a number of years ago. These include having an explicit government goal of close to zero smoking prevalence. Some people have interpreted this as being anything under 5%. Though others say that that's still too high, because that would still be quite a substantial number of people dying from tobacco-related disease if we realise that, you know, at least half, if not more, of people who smoke long-term will die from a tobacco-related disease. It also, we also need a target end date for achieving this. So these researchers propose that a maximum of 20 years would be still considered an end game goal. And you also need a strategy, because a goal without any kind of plan for how you would achieve it's pretty meaningless. So a clear plan which outlines which policies will be used, and these are accepted as being policies that will go beyond the current incremental approach, and that this would be needed to outline a credible endgame strategy. So these authors also identified that an overall smoking prevalence of less than 15% was probably needed before you could start really planning for an endgame, and also public support for ending smoking was needed. Political leadership would be necessary, and a general consensus among the public health community on which approach should be taken would also be quite valuable in progressing this. So there are a number of countries that have set what could be considered an endgame goal. So amongst these are New Zealand, Ireland, Sweden, Finland, the United Kingdom, the United States, Australia, Scotland, and Canada. And these all have various end dates ranging between 2025 and 2035. So there are a number of countries that are setting goals that they hope to achieve that will, you know, could be considered an endgame goal. So I previously mentioned that it's generally recognised that the current business as usual demand reduction approach is unlikely to be sufficient to rapidly and permanently reduce smoking to very minimal levels. And there has been a growing discussion about what are some possible options that could achieve, again, a more rapid decline in smoking and permanently reducing smoking. So I've categorised these roughly into three types of approaches. These include setting product standards for cigarettes, such as nicotine content, new approaches to regulating the supply, and finally, more intensive versions of current approaches. So that could be taxation with very high increases in taxes. It's important to point out that criminalising tobacco use is not being considered under any of these proposals, and everyone that I have seen writing about the tobacco endgame has been clear that there's no intention to ever make tobacco an illicit drug that would result in people being charged or anything like that for tobacco use. So there's also a growing discussion about what the rationale is for changing how we regulate tobacco products. And this is based on modern consumer expectations of product safety regulation. So on the slide, we have some examples of products that have been either completely removed from sale or have had the conditions of supply changed to better reflect the public health risk of the products. So we have some prominent examples here, such as asbestos products, leaded petrol, lead paint, DDT, organochlorine pesticides such as dieldrin, and even toys like yo-yo balls and jewellery that can pose a choking risk. And there's also a range of products here that are pharmaceutical substances that have previously been, say, over-the-counter products that you could purchase, and they've either been removed from sale or had their availability restricted. So it's just demonstrating that, you know, revising the classification of consumer and pharmaceutical products is something that is regularly done as a way to improve product safety, public safety. And so there's an argument for, well, why shouldn't the same approach be done for tobacco? So the current classification of tobacco cigarettes as a general consumer product that anyone can sell is really inconsistent with the level of harm that this product causes. And particularly, you know, we can see that there are other products that have been restricted that cause less harm than tobacco products. So, you know, it's worthwhile us considering whether this is really an appropriate way of regulating a product that causes so much harm. And in Australia, the regulation of smoked tobacco products is also inconsistent with the approach taken for other non-therapeutic nicotine and tobacco products. And these are ones that confer lower health risk than cigarettes. So for example, in the middle, we have a product called Swedish Snooze. And there's good evidence from Sweden where this product is a traditional tobacco product and is what has been widely used for many years, that shows that the health risks are likely to be a very small fraction of the risks of cigarettes. But in Australia, the domestic supply of snus was banned federally in 1991. So that's a product where there has been a sales ban implemented in Australia. And in the corner, we have an example of nicotine e-liquid for use in vaporizer devices. And these can't be sold or used without a medical prescription in Australia. So in contrast, cigarettes remain widely available in general retail stores, and there are no restrictions on the number or types of outlets that can sell them. So they're sold in stores like your general supermarkets that sell fresh food and vegetables. So it's been pointed out that this is quite an anomaly when you consider other products that are considered harmful and also addictive. It's not the way that we generally regulate addictive products. So what do the public think about changing how tobacco is supplied? Well, there have been a number of surveys that have been conducted in Australia since 2008, and they found that the majority of adults agree that sales of tobacco products should be phased out, and a substantial minority of people who smoke also agree with this. And also looking at it the other way around, so that's people who support it, but also there are if we look at the percentage of people who oppose it, it's even smaller. So there's only a minority of people, including people who smoke, who oppose phasing out cigarette sales or think that it would be a bad thing that cigarettes were no longer available. So there is actually quite a higher level of support than maybe initially thought for you know, removing cigarettes from the retail environment. So a complete ban on all sales is not the only option we have here. There are a number of different models that we could look at that would change the way that tobacco is supplied, that may also achieve a rapid reduction in smoking while still keeping some legal supply options open. So on this slide, I've listed a number of different models that have been discussed in the academic literature. I can't go through them all in detail, but I'll just run through a brief overview of them. So firstly, we have a proposal for a regulated market model. And this is one where there would be a single national tobacco products agency that will be operated with a public health mandate. So they would be required to supply tobacco in a way that would achieve public health goals rather than commercial goals of profit. And so this agency would become the sole supplier of tobacco products to the retail sector. And by doing that, it could control what types of products are available for sale and under what conditions tobacco products could be sold. So they could specify that retailers would need to also supply lower risk alternatives to cigarettes, or provide smoking cessation counselling, or products to assist people to quit smoking as part of if they were going to supply cigarettes. And the agency could build in incentives into the system to move consumers away from cigarettes, either towards quitting or to lower risk alternatives. Similar to this model, others have suggested transferring ownership of the current commercial cigarette companies to a new non-profit entity, and that it would again have a legislated public health mandate with reductions in smoking prevalence that they would be required to meet. So these authors have suggested that this could be done by buying out current shareholders of tobacco companies. And the main goal of this model is intended to address the fundamental conflict that exists between a for-profit company that's obligated to maximise profits for cigarette sales and the public health goals of governments that are aiming to minimise smoking so that they can improve health outcomes for people. So again, this is similar to the market model, but regulated market model, but it goes a little bit further to outline a way of actually achieving this. So another model would require individuals who wished to purchase tobacco to obtain a licence with sales supplied by licensed vendors. So this is known as the smoker's licence. The licence would limit the amount of tobacco that could be purchased and provide incentives for surrendering the licence. So the idea here would be that it would prevent impulse purchasing. Once people had decided to quit smoking, they would surrender their licence, they would get an incentive for doing that because they would get some money back on the licence. And because they would need to get a new licence before they could purchase tobacco again, that would help with relapse. So if they were just suddenly feeling that they would really like a cigarette, if they would be able to just walk in and buy it, they'd have to actually go through a whole process of applying again and making that decision to start purchasing cigarettes again. Another simpler option that's been proposed is just under the title of abolition, which is just banning all commercial cigarette sales. So under this model, the author suggested that individuals should be allowed to grow their own tobacco for personal use. And potentially there might be some other like non-profit type models available there. A stage phase out could also be implemented by raising the legal purchase age annually by 1 year each year. This would create a new generation who would never be legally sold tobacco products. Hence, this proposal is known as the tobacco-free generation policy. So this is not necessarily changing who can sell tobacco products, but who you can sell tobacco products to. And it would just gradually phase it out over time. Other proposals include reducing the number of licensed tobacco vendors allowed within a geographic area. So this might be on population size, or restricting the types of outlets that can supply. So the types of outlets that have been suggested have included licensed specialty stores such as tobacconists. This actually already exists in France. Only tobacconists can sell tobacco products. Also 18+ stores, licensed alcohol outlets, pharmacies is another one that has been proposed. And even some people have proposed making it only available on medical prescription. So interestingly, that would actually mirror the supply restrictions that are imposed on nicotine vaping products in Australia if that was to be implemented. So lots of different options that have been put on the table by different researchers. So in terms of product standards, that's another approach that could be used. So through setting a product standards on smoked tobacco products. So in Australia, we already do have a limited number of product standards for smoked tobacco products. At the state and territory level, there are bans on fruit and confectionery flavoured cigarettes. While at the federal level, there's a reduced ignition propensity standard. So that specifies the time it takes for a cigarette to self-extinguish once you're no longer puffing on it. And also at the federal level are packaging and labelling requirements for tobacco products. So the number of product standards that are implemented in Australia are actually pretty limited. but they, address some factors such as demand reduction, I guess, by removing some of those sweeter flavours. But there have been a number of additional product standards that have been proposed that could be implemented, and these may have a greater impact on reducing demand for cigarettes. These include a limit on the amount of nicotine allowed in the tobacco within a cigarette, banning or restricting a wider range of additives, such as banning all flavours, not just those fruit and confectionery flavours, and banning the addition of filters to cigarettes. So that's also been proposed for environmental reasons. So filters are an example of a single-use plastic that ends up in the environment and contaminates waterways and impacts wildlife. Also, setting a performance standard has been proposed. So that would be based on reducing the so setting a maximum emissions level for harmful chemicals, with the idea that those products that are emitting the most chemicals would be removed from the market. So I've got an example here of a paper where this suggestion's been made that you could use the heat not burn products. So they're these modified cigarettes that are put in devices that just heat up the tobacco to produce the vapour. So this author's suggested that maybe those products could be used as setting the standard for the maximum amount of harmful chemicals that a cigarette could produce, and manufacturers then would have to either change their manufacturing method to meet that standard, or else the product would not be allowed to be sold. So that's one option. Others have also suggested that nicotine vaping products are, an example of a substitute product that could be used for setting the standard. So that's products that heat liquid containing nicotine rather than heating tobacco. And so that would actually result in an even lower level of emissions that would have to be met by cigarette manufacturers if they wanted to sell their products. So are any jurisdictions actually considering implementing any of these policies? Well, the answer is yes. So here, one of the examples is setting a maximum nicotine level for cigarettes. And this was first considered by the US Food and Drug Administration in 1994, so quite some time ago. And then it was proposed again in 2017 by FDA Commissioner Scott Gottlieb. But he left in 2019, and there wasn't a lot of more discussion about the policy after he left. But just recently, there's been reports that the Biden administration is now considering progressing this policy. So we may well see this happening in a major cigarette market of the United States. Also, the New Zealand government is currently consulting on an action plan which outlines a number of proposals to achieve their national smoke-free goal of 2025. So these include a number of different options to make smoked tobacco less available, and these range from reducing the number of retailers allowed within a geographic area based on population density, restricting sales to specific types of stores such as pharmacies, and also the smoke-free generation policy has also been listed in there. So that would ban sales to everyone born after a certain year. There are also 3 policies proposed which would make smoked tobacco less addictive or appealing, including reducing the nicotine content to very low levels, banning filters from cigarettes, and banning all new product innovations that could make smoked tobacco products more addictive and appealing. So this is preempting some potential responses from the industry where if they tried to, say, remove nicotine from the cigarettes, that they may try to counter that with some other approach that would still maintain that addiction to cigarette smoking. And finally, there's also a proposal to set a floor price for tobacco products to make cigarettes less affordable. So if you're interested in reading more about the New Zealand Consultation Action Plan, you can find the discussion paper at the web address at the bottom of this slide. And that's consultations open until the end of this month. So in addition to these national examples, there are also some local governments that have taken the step of ending tobacco sales within their local government areas. So there are 2 adjoining councils in California, Beverly Hills and Manhattan Beach, which have ended all tobacco sales last January. So this has already happened in some places. In Minnesota, there's Bloomington City Council, and they announced that they would not be issuing any new tobacco retail licenses. So all tobacco sellers in that city have to be licensed by the council, and they're not going to issue any more license. Existing licenses aren't going to be allowed to be transferred to a new licensee, and they'll be sunsetting all the existing licenses. So this is, I guess, a slower way of phasing out tobacco retailing in their jurisdiction by just gradually letting these licenses lapse and be removed. In Australia, there was also an attempt to introduce the tobacco-free generation policy in Tasmania in 2014. So a private members bill was introduced to the Tasmanian Parliament by Ivan Dean, who was an independent MP. It was ultimately not successful, but it did generate some discussion in the Parliament. And also amongst that was advice from the Anti-Discrimination Commissioner, who confirmed it would not be considered unlawful discrimination. And there was also no significant legal impediment to implementing it that was identified. So it was an interesting result there that while it didn't go ahead, it did actually generate some discussion of that this may be something that could be done. So despite these examples internationally and within one state in Australia, there isn't currently a national plan to implement a tobacco endgame strategy in Australia, although there is potential for one to be developed. So, for example, as a party to the World Health Organisation's Framework Convention on Tobacco Control, Australia is committed to implementing standards for tobacco products. In the last report to the WHO on progress in this area, the Federal Health Department did indicate that product standards would be considered as part of a review of national tobacco control laws. And also the Federal Health Department recently conducted a public consultation on a draft National Preventive Health Strategy. So this draft strategy included a goal of achieving less than 5% smoking prevalence by 2030. So that brought Australia into having an endgame goal. And also it listed a number of general approaches, including reducing tobacco affordability, increasing the regulation of the contents of tobacco products, and also reducing the supply and availability of tobacco products. So there are some signals there, I guess, that Australia is moving towards an endgame. However, there are no details of what exact policies would be considered to achieve these goals. So how a tobacco endgame could be best implemented in Australia is an area that hasn't been well researched to date, and there are a number of priority areas that could help inform development of an action plan for Australia. So, for example, we don't have good estimates yet of the risks of implementing these new approaches in Australia compared to the established risks of continuing the current trajectory. So currently we're on a slow rate of decline in smoking prevalence, but you know, we could possibly speed that up if we introduce some new policies. There's also been very little research into equity impacts and the impacts on different populations of these potential policies. The illicit market also, there hasn't been a lot of research done on how that may be affected and what could be done to minimise the growth in illicit tobacco. And there's also been little research on which policy options are most acceptable to stakeholders and consideration of which ones could achieve the best outcomes. So to fill these knowledge gaps, I and a team of 19 other investigators have established the Centre of Research Excellence on Achieving the Tobacco Endgame. So this centre is funded by a competitive grant that was awarded by the National Health and Medical Research Council. And our team of 10 chief investigators and 10 associate investigators are located in universities in Australia, New Zealand and Canada. Our overall aim is to outline an evidence-informed tobacco endgame strategy for Australia. And we have a number of specific objectives, including estimating the impacts of various endgame policies for different population groups, identifying legal barriers and enablers for these endgame policies, determining stakeholder support for endgame policy options, including policymakers and also the public, and particularly in considering populations who experience a higher burden of smoking-related disease and of course of people who smoke. Also to inform the development of communication strategies about endgame policies. We've seen with the current COVID-19 pandemic how important it is to communicate issues such as health risk and policy responses in a clear way so that the public are well informed and understand the issues. And we also want to make the results of the research that we conduct available to policymakers in a timely manner and in formats that can help them make decisions as to which policies are likely to be the best choices for Australia. And an important goal is to contribute to public health research training and leadership development. So we have a number of research students that have already started, but we are still also recruiting students. So this this diagram just demonstrates the 4 programs of research that we have for the Research Centre. And these 4 research programs are all intended to interact and inform each other, so kind of a cyclical process. The first program of research, represented by the orange quadrant, is focused on estimating the impacts of tobacco endgame policies. So this is involving observational studies such as surveys, which measure people's cigarette purchasing behaviours and quit attempts in response to policies as they're implemented in Australia and also in other countries. And we'll also be using experimental data where appropriate, such as asking people to complete purchasing tasks under different scenarios, such as different costs of products. Also, simulation modelling will be used to convert data such as this and estimates of policy impacts into estimates of health impact. The blue quadrant is our legal and regulatory research program. So here we're seeking to understand what are the legal barriers and possible pathways for each of these potential endgame policies. So we're reviewing previous legal cases, current laws, and also considering how tobacco endgame policies fit within international frameworks that Australia is a party to, such as the Framework Convention on Tobacco Control. This program of work will inform the feasibility of implementing the different endgame policies in Australia. So there may be some policies that are easier to implement than others, and that may be a consideration. The purple quadrant represents our research that is focused on understanding the potential unintended consequences of tobacco endgame strategies and developing mitigation approaches that could minimise these risks. So some examples of the scope of work is examining ways we can increase the quit success amongst people who are making a quit attempt, particularly people from populations who currently have high rates of smoking. And they also are likely to need additional support to quit. And so that's an important program of work that we're conducting. We're also looking at issues such as the illicit trade and considering impacts on business, such as tobacco retailers. The green quadrant is our stakeholder consultation research. And this is where we will gather views from a wide range of people from different population groups, particularly those with higher smoking prevalence. And we want to understand any concerns they may have about the proposed endgame policies and which options they think will have the greatest impact, and identifying which ones have the greatest support from policymakers as well as the general public. And part of this program research will also involve developing messages that communicate these policies to help inform public consultation. So how far have we progressed with this program research? Well, we only officially commenced in November last year, so we've been working hard at establishing a number of research projects on these topics and also recruiting research students to join our program. We still potentially have some research projects available, so any high achieving potential candidates out there who may be interested in pursuing a research higher degree on this topic are encouraged to get in touch for further information. We're also planning to hold our first research symposium next year, where our research findings from the first year of operation will be presented. We also have a website for the centre, so I encourage you, if you want to know more about what we're doing in our activities, please visit our website, which is up on the screen. And you can also subscribe to our mailing list if you go to the Contact Us page on there. And also we have a Twitter account, so follow us on Twitter, and we will tweet papers and relevant information. So that's all from me. Finally, I'd just like to put out, I guess, a shout to any tobacco or nicotine researchers that may be watching. Let you know about our professional society, which is the Society for Research on Nicotine and Tobacco. This is an international professional society for researchers, and we also have a local Oceania chapter. So if you are doing research in this area and you haven't heard of us or haven't joined SRNT, please consider joining if you're in our region. So we provide support to researchers on research in this area, things like conferences. So there's an annual meeting, and also we will be having, we have already had local conference in Sydney a couple of years ago, and we'll be having more coming up too. And we also run some online events too. Okay, so that's all for me. Thank you very much for your time and for your interest in our research.
Brilliant. Thank you so much, Coral, for such a really thorough and comprehensive presentation that really took us through all that's been happening so far and where your research and the Centre for Excellence is going in the future. That was quite insightful, I thought. We had a few questions, so and there's been also some people posting some information in the chat. So for those of you who are interested in some of the stats and details, there are some responses in the chat. And there were a couple of questions related to that's looking at, you know, the illicit supply. So things like chop, homegrown tobacco, and whether there's been an increase or in the sale or purchase of that compared to, since tobacco use has been on the decline. So there's, did you want to comment on that, Coral? There has been some information put in the chat around ATO looking at that, but there's not much other information at the moment, I don't think.
Yeah, so the illicit tobacco market's one that I think hasn't been so well researched in Australia. And there are reports and concerns that the illicit market has increased, but there isn't a lot of evidence for, say, major increases. So it's something that we need to monitor and get better at monitoring. You know, I think there's a lot we could learn also from illicit drug researchers in the tobacco space, because obviously it's a lot of the same issues here of how do you measure an illicit market, because we can't use sales data and so on, and people can be reluctant to come forward to admit to purchasing illicit products. So this is something that I think that, you know, it's the illicit market is there already. It may grow as we increase, you know, tighten up the supply and so on of the illicit market. But it's something that we certainly can do something about, and there have been a number of proposals. So there's a protocol for eliminating illicit trade from the WHO that Australia hasn't actually endorsed yet, but they could become a party to that. And there's a number of recommendations in there how we could control the illicit market.
Lovely. There were a few comments and questions related to if products are regulated by decreasing the amount of nicotine in cigarettes. In terms of harm reduction, how would that be impacting on people, given that what we've seen often is that people will try to smoke more heavily to get that nicotine hit, and the other chemicals which are much more harmful continue to be included in cigarettes. So any comments on that one, Coral?
Yeah, so that's a great question. And that's been one of the concerns, I guess, when the policy was first proposed. So you may know that light cigarettes, they're normal tobacco cigarettes. They've just had some holes punched in the filter, and that just dilutes the smoke. And that's not actually what we're talking about here. So those cigarettes give light, I guess, lower nicotine readings when you smoke them through a machine, but people do compensate and how they smoke them to get the same amount of nicotine. But with these new very low nicotine content cigarettes, that is the actual nicotine in the tobacco itself has been mostly removed. So they're very, very low level, and they simply can't be, you can't adjust your smoking enough to compensate. So there have been a number of clinical trials which have been really important in establishing that compensating smoking doesn't occur, and actually people do tend to reduce their exposure when they switch over to these cigarettes. People also find them quite non-reinforcing, so they tend to not continue with them. So they could trigger quitting if they were the only products that were available. So yeah, it's something that, if you smoke them the same as a normal cigarette, it would just have the same health risk. But the idea here is that people would stop smoking them over time, or smoke far less of them.
Thanks, Coral. There was a question around, I guess, the broader policy there, that often the endgame policies are adapted for the high income countries, and a lot of those strategies we could see probably would work in wealthier nations. Do you have any information about endgame strategies and policies for those middle to low income countries where in fact smoking is often higher?
Yeah, so this is a really interesting point, because in New Zealand, it was the Maori Party that were really progressing this and championing this idea. And the reason they were doing that is because they felt that the current approaches hadn't really massively reduced smoking amongst their community. And so they, even though there's still high smoking prevalence amongst the Maori population in New Zealand, this is supported by the leadership, and it's seen as a way of actually being more equitable, because some of these proposals actually change the environment rather than just relying on individuals changing their behaviour. It's actually creating a more supportive environment for people to not smoke. So there have actually been, just trying to remember, I can't remember, there was one of the islands in the Pacific actually did set a smoke-free goal, and there was some discussion of that. I'm not sure how much progress has been made, but it may seem like this is a bit far off for low and middle income countries that have higher smoking prevalence. But, I think what we will see is that as it's rolled out, as there's progress in these high income countries, these innovations tend to progress on to other countries as well and become more widespread. So I don't necessarily think that it's just for high income countries. The low and middle income countries, that may come a bit later, but I think there's a lot that they can then learn from how it's implemented.
Excellent. That's actually a nice link into the next question. I guess that was at a sort of national level, and it was good to hear that sort of consultation was happening in New Zealand from the Maori groups that were leading that. But recognising, as you mentioned before, Coral, that there are the populations that are more severely impacted by smoking or have higher rates of smoking tend to be lower socioeconomic, rural and remote, our First Nations people, and people with mental health issues and substance use issues. So in terms of the monitoring impact that you mentioned in your circle, and things like surveys, how might they be adapted to sort of capture the information from those target populations?
Yeah, this is something that we're really looking into how we can do this, and we will probably be needing additional funding to do that to capture. But we're looking at things like whether we can add in some questions into existing surveys and studies that are being conducted with these population groups to try and capture their views and facilitate some consultation and try and understand what their concerns are and what their preferences are for some of these policies.